Our next speaker is Dr. Jason Newland, and Dr. Newland served on the planning committee for this event today. He's the Associate Professor of Pediatrics at Washington University Medical School and Director of the Antimicrobial Stewardship Program at Children's Hospital in St. Louis. His former position, he was on the faculty at Children's Mercy Hospital and Clinics in Kansas City, where he was the director of the AS program and the medical director of patient safety and systems reliability. He said to me before I started, "You don't have to read everything that you have there," and I think he's really serious. So he's over my.
Right.
Okay.
I want us to do this on time,
okay.
right? I mean, and then if I'd known you were reading all of it, I wouldn't have sent any of this.
Okay. Well, actually, I don't think you did. We just made it up. But if
It's true.
let me just tell you that he. Let me read. I won't read where you did all your fellowship
just
and
go
that
to the
kind of
bottom.
stuff. Oh, yeah. His current research spotlights the use of antimicrobials and the impact of an antimicrobial stewardship program at a children's hospital. He's the co-founder of SHARPS. Some of you may have heard of SHARPS. Those of you who are in the PEDS arena would. Sharing Antimicrobial Reports for Pediatric Stewardship. He's the co-founder of that collaborative, and its purpose is to improve antimicrobial use in children, comprised of 42 children's hospitals in the United States. This large national collaborative of stewardship programs is dedicated to the appropriate use of antibiotics for hospitalized children. The other thing that I will tell you is, he just went from the blue side of the state over to the red side of the state. Not talking about politics, folks. We're not talking about politics. We're talking from the blue royal side over to the red cardinal side, but he's still a true blue royal over in the St. Louis area. Help me welcome Jason Newland.
Thank you, Shirley. So, Shirley has, you guys, what you don't know about this is that the reality of us all being here is because of Shirley and because she is so passionate about making sure we're all ready for this and what we're going to do with stewardship. So I just want to give a big round of applause for Shirley, all your great work and getting us here and doing this. Also, we're blessed to have great speakers, and I think a lot of that, with Robin and Rebecca and Arjun and the crew coming it's a real treat. And being someone that's practiced on both sides of the state in regards to Missouri, it's exciting, and this is an exciting time. And I also want to just thank you all for being here because we are trailblazers, as I think Arjun mentioned earlier. There's only one other state that has a mandate, and that's California. And I was shocked to think that he thought our mandate was more impressive than California's because they've been doing this since 2009. And I think a lot of that has to do with what we're going to be required to do, which is the fact that our data, our antimicrobial use data, is going to be required to go into the antibiotic use module. And so I think that's, to him, is obviously a big deal, and it's going to be a big deal for us. So my hope is to kind of talk about data, how we can use it. And many of you guys know this. And I hope to add upon what you've already heard, build upon what Rebecca and others have talked about today. I do have some disclosures. I've had a grant from Pfizer that started that large national collaborative we're a part of, and then been an advisory board member for a rapid diagnostic company. So here are my objectives. I want to describe data and then list potential effective strategies, both inpatient, and I have the role of talking a little bit about outpatient. So I'll give you a couple of interesting studies around outpatient as well. But before we get started, because I realized, or I thought maybe we wouldn't know this, but I want to find out these following questions. And you can just show by raise of hands. I don't have a clicker thing, or we won't do poll everywhere on your phone. So, and you can, in this question, you determine what you think is active or not. You don't have to go by any definition. So the first question is, my hospital has an active antimicrobial stewardship program. All of those who have an active one, please raise your hand for yes. Okay, that's pretty good, about a little over half the room. How many would say no? Okay, so there's others. Good. All right, next question. I regularly look at antimicrobial prescribing data for my hospital. How many say yes? Okay, not as many hands, but okay. Next, I regularly share our hospital's antimicrobial use data with frontline providers. Oh, good. We have a few. We have a couple. That's good. And we're going to come talk to Alex and Joe. I was one of these others. Good. All right. So I think that's telling, right? The reality of it is this question here is going to be one of our core elements. So we're all going to have to start figuring out how we're going to do that better. And I'm hoping that with this presentation, you can have some ideas. And hopefully I can even think of better ideas, because that's not been something I've been strong at in the programs I've been involved in as well. Okay, so I'm going to go through these different bullet points throughout my talk. One, identifying areas for improvement. So how can we utilize data for identifying areas for improvement, and what kind of data is out there? And this will relate to a lot we heard about the SAR that Arjun has spoken about and others have today. Talk about implementing effective strategies. You've heard, I think, a great talk by Rebecca on a framework of doing that, which I really, really like. I'm going to steal that from you because I think it's fabulous in thinking about how you strategize. But I'm going to do it in the context of the IDSA guideline. As Rebecca kind of showed that, I'm going to kind of go in a little bit more depth there. And then lastly is, how do you evaluate? So, because I look at data as, how do we identify what we're going to do, and then how do we evaluate what we're doing to demonstrate it works? The reality of these programs, as you all know, is that our consumers of the programs are the frontline prescribers. We're going to be involved and engaged in what they're doing, and we need to show them that what we're doing is working and what they're a part of is working. And so we'll go through some of that and talk about some process measures and some outcome measures. Okay, so identifying areas for improvement. Well, first off, there's regulatory measures. There's the sepsis metric. That's about stewardship. You can sell the septic metric with stewardship, because it is the one place where you can say, hey, look, we're not always about stopping antimicrobials. We're not always about saying you can't do something. We really want to help you in this. And that's a key place that stewardship can definitely be involved in. The other thing is avoidance of treating acute bronchitis. There's obviously the surgical care improvement project and metrics, all that are tied to money that stewardship can definitely be involved in. And most of you probably have already accomplish those things, but again, it's something that you can do. The second one is benchmarking data. How do we utilize that? And I'll give you a little example of some studies that I've done in the past. But again, you can utilize that benchmarking data to identify potential areas. And I think that's the key. And I think Rebecca laid that out very nicely to say, hey, look, our metrics right now for benchmarking are quantitative based, right? They're not appropriateness based. They're not the optimal therapy based. So again, it's not saying, hey, I'm higher than everybody else, therefore I'm wrong. And I think that's the key that we have to remember in these. And then finally, I think where you find your passion, or the areas that concern you, is oftentimes the areas you're going to be most successful at, because you kind of have an idea, it's something that you feel strongly at, and you'll have the passion that'll oftentimes drive others to improve. So I want to go over one concept here that I think we've talked about, and probably many of you already know this concept, but I want to kind of show it on a table that I've stolen from somebody else in the past. And let's talk about days of therapy and length of therapy. And Rebecca mentioned this, and which is important to think about these distinctions. So days of therapy is the total number of antibiotics and the number of days they're on the antibiotic, right? So it's giving you two aspects, or you can think two concepts there, right? So amount that you're receiving, as well as how long you're receiving it for. And then there's just length of therapy, which just says, I don't care how many antimicrobials you're on, but I'm going to count the length, which matters, because you could do a ratio where you did days of therapy over length of therapy, and that will give you a sense of how many antibiotics you're using per patient in some respects. So you can see here in your respective screens, I don't know which one to point at, so I could just go around the room, but that one, this too far away. We'll go not with that. So if you look at number of antimicrobials, we had 3, duration 4. The days of therapy would be 12. The length of therapy would be 4. So if we did this example, right, number of antimicrobials 2, duration of therapy 5, your days of therapy would be 10. Yes, I heard that. And your length of therapy would be 5, right? So I think it's important that we remember these sorts of aspects, and they are different. The metric you will see presented and that continue to be presented is days of therapy per 1,000 patient days. That's the common use metric that we're still using. That's what the antibiotic use module is based upon. But I do believe strongly that the length of therapy can provide us additional information. I additionally think, as we think about these metrics, is if you have a program that utilizes, let's say, piperacillin tazobactam to treat perforated appendicitis. Piperacillin and tazobactam, obviously, Zosyn can be considered a broad-spectrum antibiotic. In the pediatric world, we like to use ceftriaxone metronidazole. We had one antibiotic that I would argue is broader than or broader than ceftriaxone and metronidazole. But if I make that change, what happens to your days of therapy? It doubles, right? So again, I think that's to demonstrate that our metrics still are in development, one of which we need to think about how we're going to measure our spectrum, right? How do we have a spectrum score from, oh, look, this hospital is using narrower antibiotics versus broader, and how does that fit in the context of appropriateness? Okay, so this crazy figure. So now you know days of therapy and length of therapy. In this figure, this is a study that was kind of demonstrating what the SAR would be like. So if you say, hey, I want to get my SAR, which by the way, we all will get, it's going to give you this ratio of observed over expected. And in this case, this Ron Polk out in Virginia basically was look at all these hospitals, a part of a large academic health centers across the country, and had length of therapy in one bar, days of therapy. And these hospitals could see any of those above 1 were outside the range of all the other hospitals. So the key about the observed to expected is the expected is all of the data that is compiled by all these hospitals. That's what gives you ends up giving you that denominator of expected, and then it's going to give you your observed. The SAR is going to do the same thing. Okay, so we're going to have that same capability. The other thing that was done in this study was, okay, now I'm going to drill down, right? So I'm going to take observed to expected, and now I'm going to drill down to areas. And so in this example, they have a bone marrow transplant unit where their days of therapy had a observed to expected ratio of 2.5, right? So it's way above what the expected ratio would be. It doesn't tell you what's wrong there, but it gives you the sense of where you would go look. Again, all of this would be what the SAR will be based on, and will be based on a lot of groupings of antimicrobials that I think in the end we'll have to see if it does benefit us as we get that data back. And I believe it will. I think when you have data, as Rebecca showed nicely, you see that people improve, and then it stimulates you to do more things. Okay, so that's kind of benchmarking and some ideas of how you could find areas to improve. So the other thing is obviously implementing effective strategies. Now, there's tons of strategies. We talked about them, and I'm just going to go through them some more. And I loved, again, what Rebecca said, and I'm basically just going to repeat what she said in many respects. One is all of our institutions are unique. I think Rebecca showed that very nicely with the different hospitals she's had and how they each had their own menu. But you have to take that into account. We're not going to all say, hey, you all have to do perspective audit with feedback of every antimicrobial in your hospital. That's crazy. Some of the hospitals will quit on us right then and there. That's not what we're after. You have to strategize those. Strategies selected must be tailored to your institution. What are your barriers? What's your low-hanging fruit? If you walk in the stewardship arena long enough, you will hear low-hanging fruit all the time. And the reality is it's smart. It's actually a very smart principle, because you will find those easy wins and people then buy into it. I think, again, Rebecca and her studies and the case studies showed that. You know that group that showed the reduction in C. diff, there was probably another group that wanted to work with the stewardship program after that because they saw the great benefit of that prescribing practices. I believe strongly in this third point. I think the best interventions are the frontline provider's idea. Now, mind you, you could think of it, but you need to get them on board to the fact that they completely believe in it as well. The more that you have the frontline provider involved in that improvement efforts, the more it happens, right? The stewardship programs are kind of on the outside. They're not necessarily always a part of the team in the other people's eyes. So if you can be a part of the team through somebody that's truly on the team, it's sustainable. And I think those in the room that have done this a lot can tell you that's probably their experience of the great improvements. I also think that, a lot of times we think up front sometimes that the physician is the hurdle. But, nurse practitioners, the PAs, those who are working right alongside these clinicians have a huge influence on what happens. And often and sometimes can be more approachable. But you'll see that that's a way to get that to that frontline provider with some successful interventions. So this has been mentioned. This is the new guideline that came out in 2016. It was under development for over 3 years, and it's the update to the 2007 guideline. But the goal of this guideline was to be more practical. So I think all of us can improve our programs based on what we see in these guidelines, especially those who are just getting started. I think this lays out nicely all the different things you can do. So I like this. Amanda Hayes, who's at BJC, kind of really laid it out and broke up into strong recommendations, weak recommendations, and I really thought that was a great way of thinking about it. So I've stole this from Amanda, so thank you. But here are the strong recommendations, and I think it's really important to look at this and think about where this comes from, and I'll show you some data about some different of these interventions. So prospective audit with feedback is a tried and true, and prior authorization also are the core strategies that have been in place and talked about since the 2007 guideline. But now the strong recommendations are also to start talking about, hey, we need to reduce duration of therapy. I think we heard Robin speak earlier today about how that has a significant impact on C. difficile infection. And CMS is very much going to be looking at our C. difficile infection rates, and that's going to be something they're focusing on in the future. No doubt, and based on what I've seen in both the new proposed condition of participation and some other work that I've been doing with them. Dedicated PK monitoring programs, IV to PO conversion programs have been shown over and over that these things work well. So let's talk about those core strategies, especially for those who are about to be starting programs or are thinking about, hey, how am I going to do this? So remember, prospective audit with feedback is, hey, I let the clinician prescribe the drug, and then I decide what those drugs are I'm going to monitor and when I'm going to come back behind that ordering of the drug to review it and to make my recommendations. Now, the big pros are you can get a lot of information by waiting and allowing someone to prescribe it. I also believe it's a more collaborative approach, right? You're not saying, hey, you got to call me before you get permission, right? That's kind of where that police mentality gets in regards to the stewardship program a lot of times. I think there is a huge con. Empiric therapy is not impacted. I mean, you should know, full disclosure, I should put this on my disclosure slide. My wife is a ID pharmacist who's also a stewardship pharmacist who is in this audience. And she conducted a stewardship program at Olathe Medical Center for years, and I often heard how frustrated she was on asymptomatic bacteriuria, right? All of you, yes, I know. This program will not stop you from treating those asymptomatic bacteria, right? They're already past, and now they've gotten like 2 or 3 doses, and you're like, oh man, it does. Like I can try to get it stopped, but so again, I think that's a key aspect where you would miss, and often more resources are really needed, right? You have to have someone dedicated to review these antimicrobials and be watching this and oftentimes going to talk to a lot of people and finding those people. So it does, I believe, take more effort. So what about pre-authorization formulary restriction, right? This is that you got to call me to get the antimicrobials, or I'm only going to restrict that antimicrobial for a certain group of people. I think you definitely impact, empiric therapy. That's the way to get rid of asymptomatic bacteria. It is more antagonistic, right? I mean, there's no doubt when you have someone want to get something and they have to go through you, that's going to lead to some opportunities for interesting conversations, so to speak. But you can utilize those to your advantage sometimes. I will say that in my initial experience in stewardship was at the Children's Hospital of Philadelphia, where this was the program we run. And they would call you up and give you all kinds of different information, but you didn't have a complete set of information. You did not have all the culture results. Sometimes they were just trying to say what they could to get the antibiotic. So I think that's an important aspect of prior approval that can lead to some maybe bad recommendations or things that aren't perfect about that. But again, an effective strategy. And I tell you these two strategies, again, they're core strategies, and I think you'll find most programs use a combination. And the reality of it is it's not just one or the other, because we have these new agents like ceftolozane tazobactam or ceftazidime avibactam. Those are prior approval right off the bat now because they're new. And for the matter of fact, most clinicians are like, I don't know what to do with them. So again, you can tailor it and then change it over time, and I think that's where those combinations work. But there's always the debate of which core strategy is superior. And there's actually been studies on this, and this is the one study that compared pre-authorization with prospective audit. And now you have to realize that the initial piece of this program was all pre-authorization. And this program, as you can see, is in Pennsylvania and had been in place for, many years, 16 years. Now, what they decided was, hey, let's evaluate what happens when we change to prospective audit and feedback with cefepime, piperacillin, tazobactam, and vancomycin. This is how they set it up. So you'll see in kind of this pre-intervention, which is to your left, you had all the drugs on prior authorization, and then to the right, they switched it. They had prior authorization, and then there are 3 drugs on prospective audit with feedback. So what they find? So you'll see that all of a sudden, you have some drugs that are kind of increasing. And those drugs would be all the broad spectrum as a whole, so that was all the group there, as well as those drugs they put on prospective audit with feedback. Though those drugs that they left on prior approval stayed low. So this is, in some respects, where some people have really believed very firmly that the prior approval is possibly a better strategy. Again, I wanted to show you this data as you think about this. I still think that there's definitely room of how you can combine these strategies, and I think we're still waiting to see more data because many of us who have done a primarily prospective audit with feedback programs have found great success in building collaborations and sometimes even more sustainable programs by doing that. So durations of therapy. I can't say, and I think durations of therapy is a huge issue for all of us and where we really have to focus on what we can do better. One thing that we've found is that just adding in some stop orders, you've seen just reduction in therapy. Now, everyone gets nervous when you say, oh, we're going to tell them they put a stop order in. What happens if they miss it? I think that goes back to the culture of how we talk about antibiotics on our rounds. If any of you got to listen to Alex and his presentation earlier, the large health system talk, I love the fact that there was this checklist that their ICU docs kind of reviewed that aspect of antibiotics was discussion of de-escalation, right? If that is a part of it, if that antibiotic timeout is truly happening every day, this isn't an issue. Stop orders for antibiotics should really be what we're striving for. And I think that will help with just the culture of antimicrobial prescribing. You can definitely put these as a part of your prior approval and your prospective audit programs. We've utilized this with quality improvement projects, just finding some areas where their durations of therapy are longer, and working on where there's evidence-based. There's evidence, especially in the adult population, where you can definitely shorten your durations of therapy. And so here are the numerous studies, ventilator-associated pneumonia, where they looked at 8 versus 15 days. Many of you know that study, and 8 days was just fine. And even I saw the VAP HAP guideline, which said 7 days as the length of therapy, and it wasn't clear to us that they even distinguished out Acinetobacter or Pseudomonas in that guideline. Adult community-acquired pneumonia is, I love the adults for this. They say 5 days, which is fabulous. It's based on great data. If you go at Johns Hopkins, I know for a fact that's one of the biggest things for them is that all their community-acquired pneumonia, even admitted, after they show improvement on afebrile, they treat them for 72 hours afterwards, and it's usually about a 5-day course. Unfortunately, in pediatrics, we have a lot of room to improve in that, as our national guideline still says 10 days based off of expert opinion and no other studies. So hopefully that'll change in the future. And then finally, cellulitis and abscess data, again, suggesting down to 5 days. So with that, what about C. diff? So you've heard all about C. diff, and I don't think I have to convince you, but this is a classic study that we all talk about regarding C. difficile infections and the importance of both infection prevention and control, as well as antimicrobial stewardship. So in this figure, you have 2 y-axes. The one on the left is actually the C. diff rate, which is represented by the blue bars, and the one on the right is your days of therapy per 1,000 patient days, which is represented by that orange line that you see kind of traipsing across that graph and then it decreases. And what you can see in the left half of that figure is where that C. diff rate continues to climb. They put in some infection control and prevention efforts, and then they added in the antimicrobial stewardship efforts, and you see this significant reduction. And that antimicrobial stewardship efforts was to reduce clindamycin, 2nd and 3rd generation cephalosporins, and fluoroquinolones through, I believe, prospective audit with feedback. So again, this has been shown over and over. This is just one of the many studies that have been done, and obviously Rebecca presented at one of her hospitals. So you will see this in the adult population by utilizing these sorts of strategies. But I think the key here, and a huge key, is the fact that infection and prevention and control must be a part of it. It's not the stewardship alone. And again, I think over and over you'll talk about that, right? Because if you can eliminate C. diff, you're eliminating antibiotic use. Just like in surgical site infection, just like in the prevention of central line infection, you preventing these infections, you're preventing the use of antimicrobials. And I think that circle you'll see over and over. So it's an overall improvement in care and an overall improvement in the value for our patients in our hospitals. So weak recommendations. So here are the weak recommendations. And when you hear the word weak, you're like, oh, those must be terrible, right? I mean, that was my first one. I'm like, you're using weak. But remember, weak recommendation doesn't mean that it's not a good strategy. I mean, they actually do work. It's just the level of evidence for these strategies are just kind of these observational studies, pre-post intervention studies. They're not these larger studies that have been done for some of the other strategies. And I say that because development of guidelines and protocols and order sets are very, very helpful. I think I would assume most people in this room who've done stewardship will tell you that they put in together an order set and they drove their practice by making like the main antibiotic selection all you could pick. They saw great reduction in inappropriate use, and they probably showed improvements overall. So I think prescriber-led review is something that we all are trying to figure out. I think there's a lot of difficulties with that, and we kind of talked about from the cultural standpoint. I think more and more we'll figure out about rapid diagnostics. I mean, it's key to start utilizing them, but rapid diagnostics cannot be done on their own, microbiology implementing them without antimicrobial stewardship and others helping review and making sure the results end up in implementation of the correct intervention. And finally, education. Education is not sustainable. Education is what we have to do, but it needs to be done with something else. You have to be building that with, doing from some perspective audit, adding in other type of IV to PO. Again, but you need to be educating. And I think obviously the core elements is going to have us do that. And then obviously Joint Commission wants us to be doing that with our patients and families. So guidelines and protocols. So you can standardize the care, which I think obviously improves prescribing and improves safety. You can focus on that treatment strategies with selection and duration. My experience has suggested that clinicians are very open to changing their selection with what you recommend. That's never been hard for us at least in pediatric space, but they hold on to their durations. Changing a duration is really hard, right? I mean, because usually your change in duration is going shorter. And for some reason, 10 is way better than 7 or way better than 5. And so again, that's just the way I think clinicians have been hardwired over time. There are limitations. They can take forever to develop if you're really going through all the steps you need from the Institute of Medicine in regards to what's a great guideline. But I think that's where you utilize national guidelines to use those to make them unique to your institution. There's great national guidelines that have been vetted and the data has been looked at over and over that you can utilize. Now, you got to make them where you can chew on them and make it easier to use because they're usually huge, right? They're 50 pages. You're like, how is anybody going to do that? So you have to kind of get a group to kind of, I would say, clarify it, make it simpler for the frontline clinician to use. And then finally, and something that I think we do a poor job just nationally in how to do this is updating. Just the other day we were on the Infectious Diseases Society of America's website looking at bacterial meningitis, and they have a guideline that is from 2004 that's being updated currently. So again, that's a long time, and what that literature then and with everything that's happening to now, you have to take into account. So I would suggest of those who are going to think about guidelines and protocols, you have to think about how you're going to review those and update those and using data to help decide how that goes, especially kind of your antibiogram data. So here's an example at Children's Mercy Hospital. We had this great pharmacist in the NICU who worked with our great stewardship pharmacist about, hey, they were tired of the way that necrotizing enterocolitis was being treated in their hospitals. And I brought this example because I'm thinking maybe many of your hospitals that might be primarily adults will have NICUs in them. So the NICU pharmacist and a neonatologist worked on this, and us as the stewardship program helped them develop with some ideas we already had. We were nervous about the fact that meropenem was being used way more than we thought it should be used in the neonatal intensive care unit. We also were wanting them to get off of vancomycin because, in the NICU, once vancomycin started, it's hard for them to stop. And so that was another goal of ours from the stewardship perspective. And so we came together, and literally the NICU pharmacist says, okay, this is how we're going to do it. Medical neck's going to be vancomycin and gentamicin. Medical neck with suspect perforation or surgical neck, we'll give them vancomycin, gentamicin, and metronidazole, and only meropenem if it was septic shock. The important part was really this part, I thought, was that after 48 hours, if their cultures remain negative, they would de-escalate from vancomycin to ampicillin. All right? So we did give them a little caveats for the real very low birth weight baby, so it gave the neonatologist some ways, okay, I'm not so comfortable. But again, this was developed in conjunction with the neonatologist and NICU pharmacist. This was accepted very quickly within the unit. So again, our worry was carbapenems. So we looked at our carbapenem data. In this figure on the y-axis, you have days of therapy per 1,000 patient days. In the x-axis, you have months. And you can see over time, our meropenem use had dropped significantly. And I didn't look at vancomycin, but the standardization within that unit for neck was very helpful for us in the end. So good practice recommendations. So I bring up NICU before, and you'll see this here. These are good practice recommendations, meaning there wasn't enough data to make any firm recommendations on what you should be doing. But the thinking is like in nursing homes and skilled nursing facilities, we should be doing stewardship. I think we all realize that, especially in this audience. And then finally, perform stewardship in NICUs. And one thing that one can consider is there are some studies that suggest limiting use of cephalosporins and carbapenems will reduce resistance as well as invasive fungal infections and is likely better for the patient. So again, I think these are some ideas that you can take, especially for those with NICUs. And being that I'm a pediatrician, I had to throw in some pediatric stuff. All right. So lastly, evaluating. So I think evaluating is key. I think Rebecca demonstrated this nicely. Evaluating your programs will help you learn where you can improve, other areas for you to implement different strategies. And finally, you need this data to go to the administration and to the C-suite to demonstrate all the work that you're doing. And I think it needs to be showing what you're doing as well as the outcomes from what you're doing, as this is going to be important as you move forward and likely to maybe even get more resources. So evaluation, there are so many different things I could put on this chart. So I think of process measures being one of those things that you have to think about in demonstrating what you are doing and how things are going. So if you're doing prospective audit with feedback or prior approval, how many reviews are you doing? What kind of actions are you implementing? What kind of acceptance rate you have, right? So are the clinicians buying in, or is there certain areas where they're not as accepting to these recommendations? I think for those that you're doing guidelines, how many of them are following the order set for that guideline, or what's the percentage of use of that order set? Could be another process measure. And then finally, the outcomes. So there's a lot of different things to think about with outcome measures. Days of therapy and length of therapy are not obviously a clinical outcome, but they are an outcome for your stewardship program. Percent antimicrobial appropriateness, in my opinion, is the gold standard. And you heard Arjun this morning talk about how difficult that is. There's a lot of gray areas of antimicrobial use in our hospitals. But we have to be striving to get at that appropriateness, because that's our goal, right? 100% appropriateness of antimicrobial use. I think cost and value is key. I think we're going to be asked for that. We're going to have to demonstrate that. Now, I put both those terms up there because cost you can show by showing reduction in antimicrobial use. You can show that possibly in reduction of maybe vancomycin levels because you're doing less vancomycin use. But what about the value? How do you account for that C. difficile infection you prevented that was suggested it would cost up to $10,000 to $12,000 currently? How do you add that in? How do you add in the fact that you picked up on a Staph aureus bacteremia where someone was going to discharge them home on azithromycin, and they were a dialysis patient, and then they found out they had endocarditis? What's that value? Right? So there's a lot of aspects to think about. It's more than just cost of antimicrobials that these stewardship programs provide to our hospitals. And again, I can show you this is exactly how to do it, but I think this is where the field has to go and for us to think about. And as you are talking about the program, one thing you can consider is, what were your great catches that would have a cost to it? Oh yeah, remember that bacteremia we caught and switched from azithromycin to oxacillin, they got treated the right way? I mean, that means something to the administrator and the legal team, right? So these are the things you have to think about as telling those stories, and patient-level stories administrators love to hear. Hospital-associated C. diff rates you've seen, length of stay, readmissions. Having mortality up on the list should be there because you got to show people that because you're stopping antimicrobials or changing, that there's not a negative consequence to your program. So they're going to see that data. Someone will probably ask you that. So my experience comes from Children's Mercy Hospital. This will give you a little what we've done with what we did with some evaluation. And Jen Goldman and Charisma Patel are here currently, and they're running the program now and have done fabulous work in continuing it. And the program at Children's Mercy was built on prospective audit with feedback, reviewing 6 days a week, talking about appropriateness and duration. And again, we believed in communication. I haven't said this, but I truly believe that these stewardship programs are social programs. These are about behavior changes and talking with people and building relationships for them to be ultimately effective and sustainable. We, in our program at that time, decided that we were going to have recommendations in the chart, but it was only if you agreed upon them. And again, communication, communication, communication. If there's anything you remember that. And what did we find? So again, this is about data. So we were looking at data all the time. And Jen Goldman published this paper here in 2015, looking at and trying to learn where our recommendations were made and what our disagreements were and where our disagreements occurred. And so you can see we reviewed lots of patients, and it's great to show your administrators, oh yeah, look at all the stuff we're doing. Right? They like to see that their money is going to something. And then you can see, hey, look, there's a lot of stop therapy. So they like to see that they're actually impacting, they're doing things. We modified therapy such as changing doses, modifying therapy being escalate and de-escalating therapies, optimizing therapy, which is changing doses and then getting ID consults. And importantly, we looked at disagreement, and that was we had a 22% disagreement, which really falls in line with, I think, most published papers, as well as with what Rebecca had mentioned earlier with her programs with the DASON network. And the other thing we decided to look at was, okay, what's predictive of having a stewardship intervention, right? So where are we making our recommendations? Now, I show you this slide not to say, okay, hey, look, here's all this crazy figures, and this is the antibiotics and all the stats behind it. That's not the point here. The point is, look at the antibiotics, and if you look, on the y-axis is the probability to have an antibiotic recommendation from our stewardship program. And you'll see the drug at the bottom with the most likelihood to have an antimicrobial recommendation was ceftriaxone and cefotaxime. Mind you, what is likely the most common antimicrobial in our hospital to use? Ceftriaxone, cefotaxime. So that was still a common drug, and we were still, recommending a lot of things on that. And so maybe that's just because we see it all the time, but you would think maybe we had some standards of why we wouldn't have to keep recommending to stop or to change the dose. So what were we missing there in regards to improving the program? The other aspect was we did the same thing for indications. And I'm just going to take you to the bottom, and there's community-acquired pneumonia. What I haven't told you is our hospital at the time, or our hospital had a community-acquired pneumonia guideline in place at this time, but it was still the most likely diagnosis for us to make a recommendation. So we captured this data. We identified another area which still is a common condition that we can improve upon. And so I would suggest, and I was thinking about this, if I was in your shoes, I'd be thinking, well, I think I could still go after common conditions. And sometimes common conditions are easier to talk about because there's more data about them as well. And so again, I think that's where I might look as a potential target if I was starting a stewardship program today. And I kind of am, so that's what we're doing. Miranda, my pharmacist, is like, yeah, you are, right? Yes. So the other thing we looked at was disagreements. I think you have to evaluate where you're not on the same page. I think you have to be thinking about that. Now, it's okay to disagree. That's what we do in medicine sometimes. But why? Where is that disagreement and what's driving that? So we looked at this. Not surprisingly, they like to disagree when we said to stop linezolid or with something with linezolid. It was mainly to stop, trust me. And carbapenems, likely the same argument was stop. So where is that? What's the indication? You'll see here in the most common indications, it was ear, nose, and throat, which I can tell you was tracheitis in the intensive care unit, and community-acquired pneumonia still. And so where is it? Why is that where the disagreements are? Who's the groups? And so again, I think that's the next step, is to evaluate further where you can improve upon those disagreements. So this is all that process stuff. I'm just talking about process data. So did it really work? Did the stewardship program really work? So I think you have to show this data to people. And in this figure, again, on the y-axis is days of therapy per 1,000 patient days. X-axis, it says years, but that data points were all in months. That light gray line is a group of 25 other children's hospitals across the country. And the black line was Children's Mercy Hospital. And you can see when the antimicrobial stewardship program was implemented. And among the drugs that we monitored, you can tell, look, it dropped. And I promise you, when you guys, those of you who have started a program and those of you who are about to start a program, this will happen to you by walking in and starting to do something. It happens. People start buying into this and they realize it's important. And we saw with the stats that there was an 18% average monthly decline. Now, that's great. We were excited. We said, hey, we're not bothering people too much and it's making a difference. But we don't have clinical outcome data to say, hey, it mattered clinically to the patients. What we did have data was that we surveyed the frontline clinicians. So don't forget, they are actually the most important part of your program. They have to be bought into this. And how do you build those relationships so they are bought in is, I think, key to make them sustainable. So we surveyed our group, and the top 3 are basically about quality. Does it make them use antimicrobials better? And has it improved patient care? And you see that they all thought that. But there was a group that said, hey, they take away our autonomy. They're threatening. Now, I'm not saying we were threatening, but we did. We took away some autonomy. There's no doubt they prescribed stuff, and we said, hey, you should stop that. And that's going to be a true feeling that some of your clinicians will feel. And so I think that's part of these type of programs. So we did try to look at clinical outcomes. And I think this is a struggle for all of us. And I'm only bringing up I show you this just to think about ideas of clinical outcomes you might think about evaluating in the future. So we basically captured agreed versus disagreed, and then we divided up these patients into different groups that we thought were distinct. So you were a medicine patient that didn't have a lot of chronic care, complex conditions, which is the CCC, and those who had a complex chronic care condition, and then we divided into medicine and surgery. And you can see that the length of stay in this between those who agreed with our recommendations or disagreed are about the same for all the groups. So I was hoping we would see a decrease from those who agreed. But at least I didn't say, hey, because of what we're doing, all of these kids are staying here longer. So that was good. But we did have this readmission. And if you look at readmission, same setup. There's no readmissions on those who agreed. Now, these are small numbers. But again, so it's suggestive of this matters. This has a clinical importance and makes our patients better. So again, something to think about. Now, again, we talked about economic impact, and I kind of jumped on my soapbox earlier. There are data that shows you can have up to $3 million within 3 years savings. That's great. People love to see those numbers. You need to use costs based on prescription or administration, not purchasing data. That's directly from the guideline, as purchasing data can have a lot of different things impacting it that makes it not as reliable. The other thing is, as your programs have been developed, and some of you I know have been doing stewardship for like 8 years or longer, it gets hard to keep moving the needle down in antibiotic use. And so if you're trying to evaluate your cost reduction comparing your last year to the previous year, it might be the same, if not more. You got to be thinking of it in regards to what the future projected cost would have been if you would have never done anything. And that's a key message that's going to have to be stated to our administrators as we continue to do these programs. And again, I talked about this earlier. Consider taking into account outcomes such as length of stay, prevention of other infections such as C. diff. You can think of surgical site infections and others. Now, maybe one that you haven't thought of and a place that you could do stewardship and start is outpatient or OPAT. So outpatient parenteral antimicrobial therapy. There's been a number of papers that have looked at this. This is just one example of a paper where an OPAT team reviewed all antimicrobials upon discharge, did number of safety interventions, right? I mean, as Rebecca stated, doing the safety interventions that impact costs as being the highest priority. OPAT is it. I mean, you can do a lot of great stuff with OPAT by making sure they get the right laboratory data, get the right duration. Heck, make sure that they're not even on the OPAT because they don't need it because you've reviewed that. This paper actually showed that they discharge delays were avoided for 35 referrals, resulting in 228 hospital days. OPAT was avoided in 75 patients with a cost savings of almost $500,000. Again, it could be a low-hanging fruit if you have a system to look at OPAT therapy in your hospital. This has even been done in pediatrics. This is a pediatric study where we know that about 3% of our discharges go home on OPAT. In this study out of Utah, 78% would have had a possible recommendation, such things as just IV to oral conversion, so they didn't ever have to get the OPAT. So again, these are potentially low-hanging fruit that are right there at that cusp of discharge that you could do a lot of big impact. Okay, in the last, 5-10 minutes, I'm going to talk about ambulatory use of antimicrobials. Okay, so to step back, how many people have clinics associated with their hospitals or urgent cares or emergency departments that they need to monitor? Okay, so we got some. All right, so if we think about this is a whole nother bucket. And I think Alex stated it best that really what I just talked about and what we've been mainly talking about in the use of antimicrobials countrywide in the U.S. represents about 3%, right? There's about 3% of overall antimicrobial use in our country. And we haven't even talked about agriculture industry, which Alex brought up and said, let's not even go there because that's a whole nother couple hours of talking. So the other part is outpatient use. And this is a recent study that just was published, I think in May, 154 million prescriptions annually in the U.S. So that's about 12.5% of our ambulatory visits will receive an antibiotic. I mean, and it's about half, so 500 prescriptions per 1,000 population, so half the population is getting an antibiotic. And respiratory conditions by far and away drive it. It's not even close for the other conditions. Interesting, sinusitis is most common. And in this study, about 30% were inappropriate. Now, you recall that Arjun mentioned that the national goal for reduction in inappropriate antimicrobial use is 50%. You can see that it should be easy for us to reduce by 50%. Shouldn't be a problem with it, as much of inappropriate use we have. So what are some strategies to do this? Now, again, you're not going to be doing prospective audit and feedback, right? Because you can't, they're gone. They're out the door by the time you even know. It's prior approval. Are you really going to make someone call you before they can leave to get the antimicrobial prescription? No, they'll figure out a workaround. So it's harder. I mean, now you're talking about a lot of behavioral techniques to do this. And so I'm going to show you a couple of studies that have been done regarding kind of these behavioral techniques. So I said audit and feedback in the traditional way of the inpatient setting, but you can do audit and feedback in another sort of way. So this is a study from Jeff Gerber at Children's Hospital of Philadelphia. Yes, it's a pediatric-specific study, but can be pertinent to other in the adult setting as well. And what they did is they've divided their hospitals into everyone getting 1 hour, all their clinics, which is about 25 clinics, getting 1 hour of education about the appropriate use of antibiotics. And as I said earlier, education alone won't always work. And so what they say is, well, we're going to give a part of the hospitals this personalized audit and feedback, which essentially was they gave on a quarterly basis all their clinicians a graph that showed their broad spectrum antimicrobial prescribing for things like sinusitis, pneumonia, otitis media. All three conditions that just need amoxicillin to be treated, right? So that's essentially what they did. So what they found? Well, it really works. All right, so and Jeff Gerber is a friend and a really, really smart guy, and he'll demonstrate how intelligent he is here in a second. But what you can see is that top bar or top circles all represent the control practices, and the orange, as you can imagine, is those that got their, hey, I'm competing with somebody else essentially, right? Looking at how I did versus everybody else. All right, but what happened was the grant funding went away. And so they quit sending those audit and feedback reports about how well they did versus their peers. And lo and behold, he got his second JAMA paper. That's why I said he's brilliant, being in the academic setting, showing that, hey, look, it wasn't sustainable. Even though they had taught him, they had showed him, but once you pulled that away, gone. So interesting, right? So, but remember this, right? There was a little bit of competition there, and it worked. All right, so that's one technique. So here's another one. So this is called the nudge. Now, this was based in adult clinics, and it was in both Massachusetts and California, and it was like 5 outpatient adult clinics in LA, and a bunch more, I think, in another clinic. And basically what they did is they signed a commitment letter with a photo in an exam room. And it was a pretty big one. And it was a 1-year observation period total with interventions in 12 weeks at height of cold and influenza season. So again, it was focused really on respiratory tract infections. Now, as you can see, this is what it looked like. I'm showing my ugly mug with my crazy picture from when I first started with a lot more hair. I think a lot more hair. And you can see, it just says, when you have a cough, sore throat, or other illness, your doctor will help you select the best possible treatments. If an antibiotic would do more harm than good, your doctor will explain this to you and may offer other treatments that are better for you, and so on and so forth. So it just is explaining, right? And to see, and this was all up big and bold so you could see it. And what did they find? Well, essentially what happened is the control practices that didn't have the nudge in there, their antibiotic use increased by 10%, while the intervention, just by having a poster in a room with somebody's picture on it, decreased by 10%. So overall, you had about a 20% reduction by just putting a poster in the exam room of the provider. Pretty simple, right? I mean, I'm like, okay. Now, the question is the sustainability. With a poster in there all the time, eventually it might wear off, and that's some of the issues with behavioral economic approaches. All right, so the other interesting thing is what they stated in their discussion, and I'll read it to you. When extrapolated to the entire United States, the posted commitment letter intervention could eliminate 2.6 million unnecessary antibiotic prescriptions and save $70.4 million annually on drug costs alone. That's huge, just by a poster. So impressive. So, but there's a newer study by the same group, actually, that says, hey, let's try some other techniques. And these techniques you might relate to a little bit more as well. So this is the study where they looked at both Boston and LA, and they randomized these clinics to receive either none of these interventions, or 1 or 2 or 3. They did what they called a factorial design to try to allow you to look at all these different interventions. And they did suggestive alternative. So essentially is you come in, the doctor's about to order something or the prescriber's about to order something. It's a respiratory tract infection. It says, this doesn't need, a pop-up comes up on their EMR and says, hey, this doesn't require antibiotics. Why don't you try utilizing, ibuprofen, rest, those sorts of things, and tell them that. The next one was accountable justification. Now check this one out. This one's really impressive. So let's say they come in with bronchitis, and you try to write it for an antimicrobial or antibiotic. It would pop up and says, this isn't indicated. You need to justify why you're going to indicate it, why you're going to prescribe it. And then if you don't put anything in it, in the chart, actually this one in the chart, whatever you wrote, and also in the chart it says, no justification given. So imagine that, right? You decide to prescribe and you don't give your justification. It's in the chart so you could see it. Then the last one was peer comparison. Now, again, Jeff Gerber did this, and now these guys did, but they did it differently. They basically divided them up into, they emailed all the prescribers and said you were either if you're in the top 10%, you got an email that says, hey, you're in the top 10% of prescribing. Everybody else basically said, you're not one of the top prescribers. And that's what you got. So you can imagine, right? You think about a bunch of clinicians, especially doctors, getting that. They all want that email. So what did they see? So here's the figure. You have across here. So from left is the, that's accountable justification. The middle one is peer, and then the third is suggested alternative. Now, when you look at these, the key is to see when all these confidence intervals separate out so that you see white in between the orange line, which is the intervention group, and the control. And essentially, the peer comparison worked and the accountable justification worked. The suggestive alternatives, it kind of worked, but it wasn't significant. So, again, I took away from this with these couple of studies is make our physicians and clinicians compete against one another. I mean, it works. I mean, they will, and you give them some kind of feedback, they'll try to come in line. And so it's something to think about. So lastly is communication. So there's data, especially for those of you who have pediatric practices, where they've done studies looking at how well we as clinicians are at determining if a family wants an antibiotic, right? So whenever I've asked this in audiences, everybody almost raised their hands. Of course I can tell when somebody wants an antibiotic. Data will show that, first off, we don't ask. We don't ask if someone's really expecting an antibiotic. And generally, they don't say they really want an antibiotic. They won't say that. They might say, hey, Johnny has a sore throat and is pulling on his ear, or, Jimmy down the street's just diagnosed with strep throat. But rarely do they actually say, hey, I want an antibiotic. And then when they've done a study, this was out of Seattle, where they says, okay, let's figure out, and they let them go in the room and then come out and they asked the parents, and then they looked at it at the end. It says, when parents are not expecting antibiotics, physicians were only right 70% of the time. When parents were expecting an antibiotic, right, so this whole thing like, oh, we think they're expecting it, physicians were only right 41% of the time. And it's definitely been shown that if we think you want an antibiotic, you're getting it. Or you're getting it a lot more times than if I don't think you want it, right? Because it's the expectation, right? You want to make somebody happy. And we still want, and you worry about leapfrog, right? All these pressures that you have good leapfrog scores, or you're worried about the urgent care down the street, or an ED down the street that possibly will just give it, and all of the payment is based off of how many patients you see right now. I mean, you can see how this happens. So what we're going to try to do, one last thing before I get to that, sorry. So the same researcher said, hey, let's look at how we should talk to our patients. So one thought was positive or negative recommendation. So positive being, hey, instead of an antibiotic, I think, you should rest, and we'll give you, chicken soup, and, being real positive, never saying you don't need an antibiotic. This is a virus, being real negative. That's the negative recommendation. So she looked at comparing those two, and then lastly looked at giving a contingency plan, which could be considered as delayed prescribing for otitis media, or saying, hey, I'm going to call you back. We'll call us in 2 or 3 days if you're having problems. So they looked at this data. They had 28 pediatricians, and basically what they found was if you do positive only, you get about a 50% reduction. If you do both positive and negative, so you're giving them something to do as well as saying, hey, this is not a virus, you had your greatest reduction. Giving a contingency plan or negative alone did not have any impact. And so it seems like maybe the script we should be using has a little bit of both, trying to help as well as being very firm about us believing this isn't a virus. So I think this is kind of where we have to go. I think in the outpatient setting, you have to be thinking how we can improve the communication. So we're on the process of running a trial where we're going to basically ask the families up front, are they expecting an antibiotic, give them some education, ask them again, and then relay that expectation to the prescriber so that they can kind of meet together and talk about it, and then give a script of how you're going to address that. So with all this, I think one, and I've talked about a number of different things, use data to identify as well as use data to show the improvements. There's a number of strategies you can use. I think that's been talked about a lot. I think you guys will do a great job, but I would highly encourage thinking about how you're going to monitor that data. And then finally, we have to get to the outpatient stewardship space. And so I encourage you, I challenge you to think about how you might do that, not only in the clinic space, but also in your emergency department. So with that, I will take any questions. Oh, right at 3:30, sorry. Okay, break. Oh, no. You're gonna find somebody else.
Stay there.
Yes.
So you talked about using length of stay as a metric, and we know there's a bunch of data on ID consults resulting in longer length of stay for things like Staph aureus bacteremia. Length of stay is an easy metric to get a hold of. Administrators like to see it, yet we know that if an ID doc touches the chart, there's a good chance they'll have a longer length of stay. They'll die less, and they may cost a little more, and they'll be readmitted less. So how do you use length of stay when we've got conflicting data showing that they die less if we touch the chart but stay longer?
Yeah, no, I think you have to, obviously in the Staph aureus bacteremia, that has a lot of factors. And I think one of the issues around length of stay is always going to be the number of other factors that influence length of stay. I think you have to look in conjunction with other things, because if you can show length of stay decreases and you can put more people in the hospital after they're out, they will like that, especially if the outcomes stay the same. And I think that's the key, right? Is how do you kind of look at this from the other impacts of those outcomes? Because the reality of it is the clinical outcomes are going to have to be kind of all together. Because if I say, hey, the length of stay is the same, the readmission rate is less, they're going to like that in many respects. So I think that probably the take home is that you got to take not just one, but how are you going to do all of them over time? And again, the real reality is we don't have great clinical outcome data at this point, I think, to show over and over. I mean, we've shown some resistance. There's data that showed resistance decreases, but we are going to have to improve, I think, our programs to monitor those sorts of things. Thank you.